Hi, yes, thank you to our speakers for answering all of those questions. I just want to remind everybody that if you have any further questions, our speakers will be able to answer them in the chat box as we go through the webcast. So now we're coming up to 10 o'clock, so we're going to take a very short 5-minute break. I'm going to hand it over to Lauren. So you're welcome to stay online or take a 5-minute break, but Lauren has some TB swag to give away. So I will hand it over to Lauren.
Hi, everyone. Welcome to our World TB Day broadcast. So I do have a couple of TB swag bags that are ready to go and ready to be given away. I'm happy to do so, but I can't do it for free. You got to give me a little something in return. And that little something is to answer a question. And I'm going to drop that question inside the chat box in just a moment. I repeat, I'm going to drop the question in the chat box. So my question to everyone is, in what year did Dr. Robert Koch announce the discovery of Mycobacterium tuberculosis? This is the bacteria that causes tuberculosis or TB. So our answer choices are A, 1843, B, 1882, C, 1910, or D, 1982. And I'm definitely seeing some answers in the chat. Now, I would love to give TB swag bags away to everyone, but unfortunately, I'm going to have to give it to my first correct responder. And in this case, looking through the chat, it looks like Annette Gonzalez, congratulations, you won. You gave my first correct answer of 1882. For context, the other answer choices are that 1843 is the year of Dr. Koch's birth. Answer choice B, we already know. Answer choice C of 1910 is the year that Dr. Koch passed away. And then answer choice D is the official World TB Day announcement. So it was a full century later from the discovery that World Day was officially commemorated. So Annette, what I'm going to do is I'm going to ask you to send me a private message to my email account. I'm going to drop my email within the chat box, and I'm going to ask that you forward me any shipping information that you would like me to send your TB swag bag to. Congrats again, and don't worry, for everyone else, there are a couple other questions that are going to be headed your way, so please stay tuned for the break. In the meantime, we're going to set up both Dr. Seaworth, Dr. Lisa Armitage, and Dr. Elizabeth Guy for our next section of our World TB Day broadcast. Thank you.
Great. Thank you so much, Lauren. So just give us a minute or two to get our next speaker situated, and we'll get back into the webcast. All right, everyone, welcome back. So now we'll go ahead and continue with our next presentation. So this is going to be a few presentations between Dr. Seaworth, Dr. Armitage, and Dr. Guy. And this session is TB, oops, sorry about that. It's TB in vulnerable populations.
All right, got Dr. Armitage and Dr. Seaworth. We are getting our technology worked out, but think we're going to be okay. We're hoping to get the sound correct. Dr. Seaworth's voice is a little soft, and we're trying to work it out so that we're not moving the camera so close that you're looking at her nasal hairs and hearing her voice. So we are going to go forward from here. We like to do this kind of in a lightning style. Dr. Seaworth and I do a lot of the discussions. What are you going to hear? Or a lot of the things that we're discussing when we're talking about new information in the literature, new topics that are coming up that are relevant to our patients. And so we're going to play back and forth. And we even got Dr. Elizabeth Guy down in Houston to join us today. So we're going to get started.
Good morning. I'm going to be starting off by talking about TB during pregnancy. I'm going to try and highlight what we do know, what we don't know, and how that negatively impacts our ability sometimes to take care of our patients as best we could, and hopefully new research will be coming soon. So I want to dedicate my presentation to the memory of this young woman who died last year from a disease which was preventable, and curable. She was incorrectly reported in the newspaper as dying of COVID. What do we know about TB rates in pregnancy? Well, unfortunately, this is the only study that really has a wide global look at the rates in pregnancy. It was published a long time ago in 2014, but the estimate from that study was at least 200,000 women each year were diagnosed with active TB during pregnancy. And most everyone agrees that this is likely quite an underestimate. What else might we know? Well, if we look at the most recent global TB report, and this is data from 2019, and we look at death rates, and women are in purple, and you can see death rates are highest, not in the oldest women, but during the childbearing age. So this gives us some hint that there may be some problems with TB and pregnancy. Going to a quick case report, my patient that was highlighted at the beginning was identified as having latent TB infection at the time of her incarceration. Chest X-ray was negative, skin test was very positive, and she was found to be in the first trimester of pregnancy, HIV negative, no known exposure, but she did have a prior incarceration, and no one knew what the TST results from that incarceration were. So could she be a converter? I think that's a very important question with a high likelihood of a yes. And is the risk of progression to TB disease increased during pregnancy? And we're going to look at that a bit. So if we look at testing for latent TB infection during pregnancy, all of the tests work, but several studies, most of them have been overseas, or all of them really, have identified that the IGRA is a better way to test than the tuberculin skin test. And overall, whether women were HIV infected or non-infected, the rate of a positive test was greater when an IGRA was done, which in this case was a quantiferin, rather than a tuberculin skin test. And you can see that these are two different studies in different locations. And if you look at the second study that was done in Western Kenya, they also looked at which tests perform best in not only during pregnancy, but in the postpartum period. And again, these are all HIV women in this particular study. The tuberculin skin test did not appear to be as helpful in identifying a positive response in either pregnancy or the postpartum period. What we do know is that it's perfectly safe to have a chest X-ray anytime during pregnancy when that radiograph is needed. Obviously, we don't do radiographs if they don't serve a purpose, but it's perfectly safe and should be done anytime you have a person with a positive TST or an IGRA, or you suspect TB disease. A chest X-ray should be done. What do we know about the risk of TB in pregnancy? Again, there are very few studies. This is probably the only really good, thorough look. This was done by Zenner, published in 2012, and it looked at a cohort of women in Great Britain and followed them over a period of time. And I don't have time to go through the exact details of the study, but it was a self-nested control study, and each woman was really her own control. And what he found was there was a significant increased risk. He noted a risk outside of pregnancy of 9.1 per 100,000, during pregnancy and the postpartum period, 15.4 per 100,000. And then when he isolated it into different periods postpartum, that he noted that the first 180 days postpartum, the rate was actually 19.2. So there appears to be a greater risk of pregnancy during late pregnancy, or of active TB during late pregnancy in the early postpartum period. So how do we decide when to treat LTBI during pregnancy? If we look at what the CDC says in general for groups who should be given high priority for latent TB infection, I want to highlight two of them here that apply to the particular woman I identified earlier. Recent contacts to a patient with active TB disease, and then residents and employees of high-risk congregate setting. She was incarcerated, had been previously. So what does the CDC actually recommend about treatment during pregnancy? Well, they tell you to test anybody that's high risk for developing TB disease, but then they say treat these. Most can have treatment postponed until the postpartum period. And so my question is really why shouldn't most of these be treated if they've already been identified as having high risk for developing TB disease? So the next concern is how do we treat them if we decide to treat? And part of the problem is the lack of data. Way back in 1993, the FDA recommended that any drug that might be used during pregnancy should be evaluated during research and post-marketing studies. Actually, very little has been done along that way. If you look at the 12 recent phase 3 and post-marketing clinical studies for treatment of LGI, all of them systematically rather excluded pregnant and lactating women. There are 3 studies that have included or are going to include pregnant women, and the first was a study that looked at whether INH preventative therapy should be given antepartum or deferred to the postpartum period. The second was a PK study with a small group of women looking at 3HP during pregnancy, and then the other study is still pending. So this was the first study that was done, and it looked at an immediate group where INH preventative therapy was initiated during pregnancy, a deferred group. They had about nearly 1,000 women in each group. Interestingly, TB developed in 6 in both the immediate and the deferred group. These were all HIV-infected women. Most of them were on antiretroviral therapy. So the conclusion was that the initiation of INH preventative therapy during pregnancy wasn't inferior. However, there was a greater incidence of adverse pregnancy outcomes. And let's look at those. You can see that the deferred group is orange. The immediate group was INH during pregnancy. And no matter how you look at it, if you pull them all together or separate out into various adverse pregnancy outcomes, the risk was greater when you started treatment during pregnancy. And this was with INH. If you looked at what some of that risk was, there were 6 deaths in this study. 2 of them were due to INH-induced liver failure. One was in the deferred and one was in the immediate group, but both of the women actually died in the postpartum period. There were 2 other liver failure deaths in women who did not get INH, and then 2 deaths that were not associated with liver disease at all and unrelated to the study. So how about what do we know with studies that we've looked at here in the US with the 3HP study? One was the initial study, and then one was the second study looking at whether self-administered therapy was equal to the directly observed therapy. And these studies excluded pregnancy, but people became pregnant anyway. And they actually identified 56 pregnancies that were exposed to INH and 31 that were exposed to 3HP. Obviously, once pregnancy was recognized, the treatment was stopped. But what did they find from looking at what happened with these women? They noted in the 3HP group, fetal loss was about 13%. In the INH group, fetal loss was 14%. No congenital abnormalities in 3HP and 2 in the INH group. But when they compared that to US estimates across the board of fetal loss of 17% and congenital abnormalities of 3%, they found nothing that was unexpected over the baseline rates of reported fetal loss and congenital abnormalities. So no signal that 3HP or INH had a role in the adverse outcomes. A second look is a small study that was done looking at, mainly designed to look at the pharmacokinetics of rifapentine and INH during pregnancy, but they also looked at the safety in this small group of 50 participants, 30 of them whom were HIV uninfected and 20 HIV positive on efavirenz therapy. And the important conclusions for my presentation today is that they're highlighted in red. No drug-related serious adverse events occurred in either women or infants, and HP does not require dose adjustment during pregnancy. So what we're left with, however, is we still can't use 3HP. A larger study is planned with hopefully more data that will then be able to use 3HP during pregnancy. But right now we're looking at rifampin, INH, either or INH and rifampin both. And really there are some concerns with isoniazid and liver toxicity during pregnancy. And my preference is to use rifampin, although we don't have data to support that. So how about treatment during pregnancy itself? And this was a larger study, and I really don't have time to go through all of it, but that some of the conclusions were that outcomes are better when treatment is early, and especially if you can treat when disease is limited. And if you look at treatment in the first trimester versus the second or third, there were no preterm births versus 33% in those who were treated in the second or third trimesters. No cases of perinatal death versus 23% when treatment was later. No low birth weight infants in the first, if treatment was in the first trimester versus 61% when treatment was deferred to the second or third trimester, and also fewer complications in the mothers. So really a very, very nice support for treatment of every TB patient as soon as the diagnosis is made, even during pregnancy, and the earlier the better. So going back to my patient, she had spontaneous premature rupture of the membranes at 36 weeks, which is early. Her infant was healthy but low birth weight. And at the time of delivery, she had a very nasty breast abscess that had been there for about a week prior to the time she delivered. No bacterial cultures were ever obtained from this breast abscess. So what happened to her postpartum? She was again incarcerated. She continued to report symptoms of fatigue. She was noted to be tachycardia at every visit. She frequently went to the clinic at the jail. She had a very persistent anemia. 6 weeks postpartum, she was having sick calls again, shortness of breath, tachycardia, fever, and cough. She was COVID negative. 7.5 weeks, more symptoms, but now she has a fever. So she gets referred to the ER and she's COVID positive. This is her chest x-ray. This chest x-ray is not consistent with COVID. This chest x-ray is a chest x-ray consistent with miliary TB. But she was treated with steroids and returned to the jail, and she actually was better for about 10 days. And then she wasn't better. 13 weeks postpartum, she was seen in the clinic at the jail and noted to have increased fever, shortness of breath, and she had O2 saturation that was only 84% and a pulse of 140. So they sent her by ambulance to the jail. She was sent by ambulance from the jail to the ER. She was admitted and several days later arrested. She was found on the day she arrested to be positive on sputum, urine, and a blood culture later for MTB and started on therapy, but she expired and had widely disseminated TB in all of these organs at the time of her death. This is almost like unmasking iris that we see in HIV. Okay, I'm just going to end really quickly with a couple of slides. TB is one of those conditions that can be exacerbated in the postpartum period, one of the most likely infections to do so. It's almost a form of immunoreconstitution disease. And this was a look at a literature review from 1966 to 2002, and they found 29 patients with TB in that acute peripartum period, either the last weeks of pregnancy or early postpartum. And they found that of the 29 patients, 27 had extrapulmonary disease. 60% of them had CNS disease. None of them were HIV positive, and they all had significant treatment delays. Outcomes were 38% died, 13% had residual functional defects. And I'm going to stop here and switch over to Lisa. This is a topic for a longer talk, I think.
Right. So we'll take all those little nuggets of knowledge from Dr. Seaworth, and you know that if you have a pregnant woman or a pregnant person and they need to be evaluated and you don't do a chest x-ray, I'm going to tell you now, we will both think less of you. So I want to talk a little bit about updates in pediatrics. So we're moved next naturally. We're moved naturally from the pregnant persons onto the delivery of the little persons. So I will point out just for some updates from some numbers. The CDC kind of put the numbers on the internet last night, and I, like a thief in the night, went in and found them. The definition of pediatric tuberculosis, just as a reminder, TB disease in a person less than 15 years old. I'm a pediatrician. For me, that goes to 17. I challenge any of you who want to argue with me to give your 15-year-old the keys to your car and the PIN to your ATM card. But anyhow, the numbers, so now the new numbers for TB cases, 8,300 of those, 317 were pediatric. That was 4.4% of cases. Interesting, these are the pre-COVID numbers here, 215 and 152. The numbers dropped for the 0 to 4. I don't know, it's had to be something with diagnosis. It stayed just flat during COVID, and then all of a sudden we're up 50 cases. So, 40 cases, I'm sorry, big increase in the numbers on the little ones, but we had an increase in overall in the pediatric numbers nationwide. I put this slide in here just to remind you, this is not really an update, but something just to remember. When you look at all cases in the US of active disease, non-US born individuals represent 71% of the cases, and 28% are US born. Flip-flop that when you do the pediatric numbers. 75% of cases of pediatric tuberculosis are US born, and only 25% are non-US born. So it's the exact opposite with the children. Some new updates from the AAP Red Book. This is the book that we all look to for for most of our updates and what is considered. The CDC tends to do to the Red Book, and the Red Book does try to align with most of the CDC policies, but the CDC does lag a little bit behind, and we try to keep the pediatric information moving in real time. And we always give a nod to Jeff Stark, who's down in Houston at Baylor College of Medicine, who has a big hand in writing them. So 3HP, I thought this was a little funny. It was written previously that the preferred regimen for children 2 years and older was 3HP for the treatment of TB infection. So now it says put that up to 5. It is important to note it is still a regimen that is still recommended for children down to 2. So it is still it has been studied, it is safe, and it is effective. But this is recognizing that dosing in children less than 5 could be a little challenging. It's a lot of medication in a single dose. So when you say it's the preferred regimen, that puts a little bit more onus to try to work on it. I will say that I've learned everything I know about it from the nurses. If you crush the rifapentine tablets, it leaves some little pointy ends that are hard to mask. If you put a little warm water in there, they'll dissolve very nice, and you can hide it in the yummies after that. But just taking into account that the 2-year-olds may be a little bit more difficult. I brought this study back. This came out last year, right before World TB Day last year. There's a shorter treatment regimen looking at children in Africa and India. We have all known as pediatricians that we're probably over-treating. We know that children have minimal disease. We know that children usually are dosed for weight as opposed to adults. I always like to, when I say that point, I like to point out Dr. Seaworth sitting next to me and Shaquille O'Neal received the exact same dose of rifampin at 600, which is probably not correct. A child, on the other hand, will receive a dose based on their weight and will be kept within a tight range. So we always knew that we were being probably more effective with the treatment in children, but they have minimal disease and we're treating for a full 6 months because that was just kind of how it was going to be. This study looked at shortening to 4 months. So you have 2 months of RIPE, and then you have 2 months with just INH rifampin instead of 4 months with INH rifampin. And when you looked at the outcomes, favorable status, 97% all equivalent in both of the arms of the study. TB recurrence was essentially equivalent, 6 in the 4-month group and 4 in the 6-month group. And then extensions of treatment, this was just provider choice. On 2 more kids, they decided that they wanted to extend treatment, and one in each group had to restart treatment from the beginning. There was an increased number of deaths, a little bit more in the 6-month group, but these were very small infants, all about less than 6 months of age, and most of them died of a respiratory illness far after the evaluation period. So exclusion criteria, if there was a smear positive respiratory sample, remember this is non-severe disease. So if there was a smear positive respiratory sample, that was considered as having a little bit more active disease. Children were aged at least, premature or age under 3 months. So they started study at 3 months. No miliary, spinal, meningitis, osteoarticular, abdominal, or congenital TB, all severe forms of TB. They couldn't be severely sick, even if it looked like they had minimal disease, and no pregnancy. So now the Red Book is now reflecting this. So it does state for children with non-severe disease, RIPE for 2 months, followed by INH and rifampin for 2 months is acceptable. The children must be greater than 3 months old. They can only have disease in one lobe of the lung, no cavities, no miliary disease, and no complex pleural effusions. So also I added in no meningitis, no bone disease, or no disease. So the shorter regimens you're going to start seeing, with children with minimal disease and non-severe, we can start shortening that up a little bit. So also for children greater than or at least 12 years of age or older, the 4-month regimen that we seen studied in adults, study 31, where you have 2 months of INH rifapentine, moxie, and PZA, and then 2 months of just INH rifapentine and moxie. Basically, you drop the PZA after 2 months. That study is acceptable and in the Red Book now, noting that children at least 12 years of age or older also qualify for that. And now they state explicitly for young infants with TB, you should be managing that with an expert. All of the guidance on drug-resistant disease has just essentially been moved out, and these 2 links have been added in. I love this one just because of the random act of cuteness with a toddler and a T-shirt that said I didn't do it. Yeah. So, but these are two guides that give you all the information you need for drug resistance in children. And then just a couple of assorted updates, TB and HIV in children. Children that are living with HIV, if they have TB disease, you can use the shortened regimen again if they have non-severe disease. Important to note, the original study did look at children with HIV. So it is an acceptable regimen. You will see us come down because usually if someone has HIV, we're doing the hard line, long treatment, but in children with minimal disease, even with HIV, you can use it. And then there was just some dosing for bedaquiline that was revised based on weight. And so, that got out of our one group, but I'm going to hand it back to Dr. Seaworth because there's a couple of new sets of studies that she and I will be presenting, and one of them looked at hepatitis C and the effect on TB.
Thank you, Lee. Just if we look at TB and HIV or Hep C virus, it kind of reminds me of the old TB HIV association, and I'm going to look at what we do know about that today. But there is a lot of TB globally, and there's also a fair amount of hepatitis C, which is chronic. And both of these populations do cause concern here in Texas. If you look at acute hepatitis C virus cases in the US over the last few years, the latest data is 2019, you see that there's been a fairly significant increase. And in large, this has been attributed to the increasing opioid use in the country over the same period of time. So when you look again at who's at risk and who should be tested, we want to make sure that we identify all the high-risk individuals, but should we also be including hepatitis C infected individuals in this group that should be identified at increased risk and should be tested? Should we also identify them as having an increased risk of progression to TB disease, and if positive, treated for latent TB infection? Often many of them have injected drugs, and there's good evidence that their immune systems may be depressed. So when we're looking at those individuals who have immune compromising conditions, putting them at increased risk for progression from infection to active disease, should we be listing hepatitis C here? Also, if we look at reported risk behaviors, injection drug use alone gets many of these individuals a look at being tested for LTBI and treated. And it's clearly the highest risk behavior associated with hepatitis C virus infection in the US. So this is a nice study that just came out earlier this year in January. And the aim of the study was to assess how untreated and treated chronic hepatitis C virus infection status impacted the incidence of active TB disease. Their hypothesis was that the incidence of active TB was going to be highest among those with untreated chronic hepatitis C virus infection, followed by those who were treated, and then lowest among those never infected with hepatitis C. This was conducted, it was a cohort study among adults in the country of Georgia who were tested for hepatitis C virus between 2015 and 2020. They excluded anyone that had a known diagnosis of active TB either before the time of their hep C virus testing or at the time of the first test. So they chose Georgia because it's a country with high incidence of TB. It's a country with a high incidence of chronic hepatitis C virus infection. And they were the first country globally to implement nationwide program to eliminate hepatitis C virus and to try to screen all the individuals in their country. So they were able to, out of the nearly 2 million that were tested for hepatitis C, they included 1,800,000 in the descriptive analysis, and then in the multivariate analysis that looked at trying to exclude other things that may be impacting the results. They had 1,778,000 individuals. So this was a bigger study than we're often able to get for our TB patients. So they found active TB diagnosed in 3,136 patients during this follow-up period. And if they looked at the incidence rate per 100, it should be 100,000 years, not 1,000 person years. Anyway, ignore that. So in the untreated hepatitis C virus population, they had 296 per 100,000, which was 4 times greater than those that were never infected. In the treated individuals with hepatitis C virus infection, they had 109 per 100,000 person years, and that was 1.7 times higher. And then those who were never infected with hepatitis C, they had 65 per 100,000. They noted that those who were treated also and had a sustained virological suppression had lower rates of TB than those who were treated but did not have evidence of sustained virological suppression. And it's not a lot lower, but it was 1.5 times higher than those never infected. So their conclusions were adults with hepatitis C virus infection, particularly untreated individuals, were at high risk of developing active TB disease, that persons with hepatitis C infection should be screened for latent TB infection and for active TB disease. And this suggests that those who are positive should be treated for LTBI, but there's really no good study looking at the safety of LTBI therapy in chronic hepatitis C virus and all of us who have tried to treat LTBI in this group sometimes are challenged to get through therapy without significant liver toxicity. So a quick look at hepatitis C virus and the immune response and why they might be included in those who are immune suppressed. And I'm just really quickly going to highlight a couple of these things. Hepatitis C virus infection is associated with impaired macrophage activation and T cell response. And that goes with the production of those macrophages that are essential for control of TB, such as interleukin-2 and TNF-alpha. It affects natural killer cells. And the viral persistence and chronic hepatitis C virus can lead to functionally inferior T cells. Even if they have the T cells, they don't work as well as normal T cells. So when we look at hepatitis C in Texas, we're not listed in the highest incident states for new acute infection, but if you look at chronic hepatitis C and the deaths that are associated with that in the United States, Texas is in the top 3 by numbers of deaths. And then if you look at rates of death with hepatitis C in the US, you can see that Texas is not in the highest tier, which is 5 to 10 deaths per 100,000, but they are in the 3.5 to 5. And I believe the rate was 4.3. You can actually click on the map if you get the actual map and see the rate for each state. So I just want to thank you. Hepatitis C is a problem in Texas, especially chronic hepatitis C, and it's maybe something that we should include in our group of individuals who should be tested and treated if possible. Thank you.
Okay, and I want to switch to the diabetics. So obviously this is a large, number of our population. At one time, I know in San Antonio Metro, about 30% of our patients were, about 30% of our patients were diabetic and had active disease. So there was a paper that came out probably about 2018, and so going on about 5 years ago. And a group in China was just looking at TB and diabetes. And they noted that there seemed to be some survival benefit for patients that were taking metformin. So they kind of honed down just to that group. And there's just been papers after papers that are showing metformin seems to have some immune modulatory effects in a good way. They're wondering if it has some antibacterial properties. But I pulled out a couple of papers. So the immune effects of metformin, I just pull this out if this, those of you who are having some flashbacks in immunology, and if it makes you seize, I'm sorry, I'll move on quickly. But importantly noted, the clinical outcomes decrease mortality with taking metformin with diabetics with TB, better glycemic control. That's kind of the effect, the expected effect of the drug. Decreased time to culture conversion. Anytime you can get someone to convert their cultures quickly, that decreases the amount of chances they're going to transmit in our community and gets the patient in a healthier place. And then decreased toxicity with the TB meds, which was kind of a shocking thing. And there are some other places that they feel like metformin is affecting the immune cascade and increased reactive series, basically different places that it is pumping the brakes on immune effects. And then this is a second one that just shows some more specific places in the pathway where metformin may be having an effect. But I looked at for just kind of updates and more recent papers that showed, some clinically, if you're looking at patients who are taking metformin or no. And this one actually was one of the earlier ones in 2018 that got everybody's attention. This showed that patients who took metformin who had type 2 diabetes decreased the odds that they were going to have, that they were actually either going to get infected with, develop TB disease. So the red lines are the patients who are, they call them ever users, patients who routinely take metformin for their diabetes, and then the blue line are the never users, people who have never taken it at all. And when you look at any TB free, free of any kind of TB, there is a gap there. If you look at pulmonary TB specifically, there's still, you have an increased chance of never having TB, not having a TB-free existence in your life during the course of the study, if you're taking it. And even the people who just took it irregularly still got some benefit from it. So there seemed to be some, benefit to taking the medications. So this was a paper that looked at pretty much a much wider, this is about a year later, they looked at everything in the databases like Cochrane databases and PubMed, did a retrospective review of all of the databases up to March of 2019. And this includes 12 observational studies, about 6,980 cases, so almost 7,000 patients with TB. And what they found from their systematic review was that, so they can only look at, in some of the studies, at whether metformin had been prescribed. So you don't know, it's like we're not DOTing people, so with their diabetic meds, so we're assuming that they're taking it, or if they're trying to narrow it down to the individuals who were filling it regularly. But just metformin prescription decreased the risk of TB, that meaning the progression of TB infection to TB disease among diabetics. Metformin prescription was not related to a lower risk of getting TB. So you can still get infected with TB, but it seemed like metformin prevented you from progressing to active disease once you did get infected. Metformin medications, so these are patients who are actually seen for treatment for TBs, and they were queried more regularly about whether they were actually taking the metformin. So those who took it during treatment for TB disease had a reduced mortality, so less deaths. I always like less deaths. Metformin use resulted in a higher probability of smear conversion at 2 months. So smear conversion, that they didn't look at culture here, but relapse was not reduced by metformin prescription. So that was the one thing that didn't seem to be affected. So now I like this study because now they're looking at, so the question is, if this drug is so great, should we be giving this drug to everybody, and whether they're diabetic or not? So this was just one study, and it's relatively small, I guess, but a pretty decent size, with 322 patients that were randomized equally to either just when they had been diagnosed with smear positive pulmonary tuberculosis. So either got RIPE or they got RIPE plus metformin for 8 weeks. And the way they did the metformin, started them at 500 for about a week, and then they ramped them up to 1,000. One of the things they noted, if you look at the efficacy in mice, there's a lot of studies in mice that show, a benefit, but the dose is closer to about 2,000 in humans. And so that was one of the things that they said might have been a limitation to their study. But they just looked at the first 8 weeks of treatment, and they were looking for, just what we do after the first 2 weeks, 2 months, we look for whether they've converted their sputum culture, and we also look their smear culture, and we're also looking for chest X-ray findings. But they were also measuring like inflammatory markers like CRP, like C-reactive protein, and ESR. SED rate, this erythrocyte sedimentation rate, just had a blank. It's always good to have Dr. Stewart here. She's like my good dictionary. But they looked at patients, all comers, not just patients who were diabetic. And their results, they did not see, when they added metformin to anti-tuberculous therapy for 8 weeks, they did not see that they had a hastening of sputum conversion. That did not seem to have an effect in this smaller group. But they found that metformin did diminish the excessive inflammation and decrease the inflammatory markers. So when they're measuring markers from the beginning, and then again, at 1 month and 2 months, and they're looking at the two groups of metformin or no metformin, the metformin group had a decrease in excess inflammation. And they also saw a reduction in lung tissue damage, basically with faster improvement on the chest X-rays. So these are, I've been kind of leading over into Dr. Guy's talk. Anytime you can decrease a hit on the lungs, we're finding that, just because you treated the TB, now the scarring that you have left over is putting the patient at some significant amount of danger. And I'm going to hand that over to the expert and have Dr. Guy discuss that next.
So post-tuberculosis lung disease. So having been involved in treatment of tuberculosis for several decades. I have personally seen these patients come back to our clinic, so we discharge them after they are cured of tuberculosis. But then sometime later, some of them will come to the clinic with shortness of breath or chronic cough, and to the point sometimes they end up in the ICU because they have had a massive hemoptysis. So we knew about patients suffering from sick consequences of tuberculosis, but I believe we really just did not pay enough attention to it. So there is increasing evidence now and increasing awareness of patients or persons who have had history of tuberculosis. They actually continue to suffer significant physical, psychological, and health impact even after they have been cured of tuberculosis. So currently, since 2000, there are an estimated 55 million persons living after having been cured of tuberculosis. So this is a 29-year-old patient. 9 months later, after being diagnosed with tuberculosis, the chest X-ray on the right still shows that there are significant densities or infiltrates, we call them, involving both sides of the lung. We can see that on the left side, there's this big density on the right side indicating the presence of fibrosis. So PTLD, post-tuberculosis lung disease, has been coined and accepted as the terminology that will be used to refer to this spectrum of disorders of people suffering from chronic respiratory abnormality. They may or may not have symptoms that is attributable at least in part to prior history of tuberculosis. So the disorders may affect the large and small airways, the lung parenchyma, the blood vessels, and the pleura. Patients may have complications by co-infections, sometimes fungi, sometimes non-TB, mycobacteria, and as well as hemoptysis, which is a commonly feared complication. They have increased risk of recurrence of tuberculosis as well. They have significant disability with economic, social, and psychological impact. Their stigmatization really does not stop even after they are cured. They are known to have a shorter life expectancy with a mortality ratio about 3 times that of persons who did not have tuberculosis. And unfortunately, because there has been lack of systematic study, there are really no evidence-based recommendations for their evaluation and management. So pulmonary function tests are a group of tests that we use to assess the lung function of any person who is having respiratory symptoms. So some of them will determine the presence of obstruction to airflow. A set of tests may measure the lung capacity, and the small lung capacity actually is called restriction. We have tests to measure the ability of the lung tissue to exchange gases, both oxygen and carbon dioxide, and we also, of course, can do arterial blood gases. Functional capacity can be assessed using several types of walking tests, as well as a full cardiopulmonary testing for those who are able to do it. So this is a study I found interesting of some 40 patients who were studied at the time of diagnosis, through the treatment, and even after completing treatment. So there was a whole host of pulmonary function testing done, CT scan, symptom questionnaire. What they found was that at baseline, the FEV1 and FVC, which are the most common measures of lung function, are actually already reduced. So this is at the time of diagnosis, and they are already reduced by a median percent predicted down to about 60% for each of the parameters, so 59 and 63. Over a period of the study, up to 18 months later, they found that the diffusing capacity, or the DLCO, actually was low, with a median percent predicted of 65%, and it remained low even after recovering from the tuberculosis. And a good proportion of patients actually had this finding of about 79%. So that's a very significant impact, I think. The CT scan also showed the development of air trapping, which was correlated with the presence of obstruction. So the bold is the burden of obstructive lung disease. In this study, they did post-bronchodilator testing and standardized questionnaires. So among 14,000 participants, they found that the odds ratio for obstruction, the finding of obstruction, and the history of tuberculosis was actually 2.5 times that of persons who did not have TB. For the presence of restriction, it was 2 times that of persons who did not have TB. What is interesting is seen in the next slide. There was some disparity between low and middle income sites compared to those at high income sites. So what we can see here is among high income sites, the odds ratio for developing restriction was slightly lower than those of low and middle income countries. This, to me, highlights the fact that lung development in childhood is definitely affected by socioeconomic, nutritional factors. And to me, that kind of underlines that aspect of lung development. So to highlight this important problem, PTLD was the most common diagnosis in a lung hospital that was newly established in Namibia. Namibia is a country with a high burden of TB, and PTLD was the #1 diagnosis in up to 16% of their unselected patients, more than asthma or COPD. And in India, in persons who had completed treatment for TB, they found that only a quarter of them actually had normal spirometry. A good half of them had restriction, and another quarter actually had obstruction. Now, for airflow obstruction, they found that the longer duration of illness and the severity of the sputum smear grade was associated with obstruction, whereas for restriction, being female and having diabetes was more commonly associated with restriction. However, sputum smear grade was also associated. And in Pakistan, in a group of 300 some patients, they found that only 17%, so 1 in 6, will have normal chest x-ray after being treated for pulmonary or pleural tuberculosis. And fibrosis, pleural thickening, and bronchiectasis are the more common findings on the rest of the population. So disability adjusted life years, or DALY, is the way that the WHO tries to quantify the burden of disease. So there are a million diseases that people can have. So for tuberculosis, so the DALY is a standardized way of determining how much burden a person or a society will have if they have disease of tuberculosis or diabetes or cancer. So the disability or the loss of life years is accounted for by the disability, loss of healthy life years, and the actually loss of life due to premature mortality. So Menzies and his colleagues in a hypothetical patient in 2019 were able to come up that a person who was diagnosed with TB in 2019 will actually have 12 years of DALY per incident case. And that is attributable to disability during the disease phase and ongoing disability during the post-TB life. However, there is increased mortality both in the disease phase, which is a little bit higher than the cumulative mortality during after tuberculosis, such that the burden is actually highest. So this is the pink is the mortality, premature mortality, and blue is disability, life years lost. Highest during tuberculosis disease. And if we think that, hey, you're cured, you can go home and live your life, no, they still have a lot of disability and premature mortality to actually to contend with. So perhaps there is a call to action to the TB community that we should start to recognize. I put myself in that category because I really was not paying attention to this, even though I was dealing with it. Recognize post-TB lung health is actually a part of patient-centered TB care. Providers need to perform evaluation of symptoms, either using questionnaires. We don't even have validated questionnaires for post-TB lung disease. We need to perform appropriate lung function testing and imaging studies as needed. Research, perhaps, into host-directed therapies, as Dr. Armitage has alluded to, is actually a very hot topic right now among researchers, but funding is a big problem because we do not even think of PTLD when you try to apply for funding when you treat tuberculosis. So we need to include PTLD in the calculation of the total burden of disease, both at the societal level and at the patient level. And last slide, I would like to leave us with this statement from a person or a patient from Dr. Alwood, who said that when we started with tuberculosis treatment, no one really told us that it would never leave us, both physically, psychologically, and economically, actually. They all continue to suffer from significant, from tuberculosis. That's my last slide. Thank you, Dr. Armitage.
So, to piggyback on Dr. Guy's, assessment, I am guilty of that. As soon as I see that, after 2 chest X-rays, there's just this quote, just scar, a just scar. So it's not active disease. My work here is done. I have cured the patient, but they have long-term outcomes that we're not addressing. There was a paper that came out that got my attention to piggyback on the adult disease, looking at the long-term impact of TB on child health. So first question is this really important? Children, I just told you earlier, tend to have minimal disease. Most children, if they don't have meningitis, should completely recover. And don't young humans have a remarkable healing properties? Can't they just heal from things? Because you have some scars from when you did stupid stuff when you were little, but those get out over time. I feel like this should not be as an important thing, but apparently, yes, it is. This is a paper that just came out in February, and I would have put the graphic up from the front page, but it's still in kind of draft form. But the methods, they enroll women between 20 and 28 weeks gestation. Now, I have never seen children enrolled in a study before they were even born. This is like the coolest thing. But they had basically they talked to the women about wanting to follow the children prospectively, and most of them they got out to an average of 7 to 8 years of follow-up. The goal was 10. Women were enrolled again at 20 to 28 weeks gestation. Every child that was born, this was in South Africa, did receive BCG at birth. So I don't think they had any cases of meningitis, or if they were few. They had informed consent to follow the children annually, and the moms were consented annually for the children. They had follow-ups here, the number of, at the number of each weeks, and then the number of months, and then every 6 months until they were 5 years old. And they were looking at height, weight, respiratory health assessment, whether or not the child was wheezing, if they'd had any lower respiratory infections, or whether they had episodes of wheezing in the 6 months prior to, to the visit that they were at since the last visit. They did do some pulmonary function tests at 6 months of year, and then yearly up to 5 years of age. And all of the children with TB were treated for 6 months. This is a little bit older study. They started off with 1,225 pregnant women. They ended up with 1,143 children. Some of the women were excluded. There were, I think, 3 sets of twins and 1 set of triplets that were included in there. And so we got to the children who were divided into children that never had tuberculosis, which was the majority, obviously, and then about 10% of them went on to develop TB at some point. So the outcomes, I say length, but I mean it's basically height. But the way the verbiage in the paper states, lower height and weight at 6 weeks old was associated with pulmonary tuberculosis. So if you were children who were smaller, and the smaller percentiles for weight and height were at higher risk of developing tuberculosis, pulmonary TB at some point in the first 5 years of their life. If a child developed TB, pulmonary TB, prior to 1 year of age, that was associated with lower height, weight, BMI at the age of 5. So these children having one bout of pulmonary TB were already smaller than their comrades by age 5. If children who developed pulmonary TB between 1 and 4 years of age were smaller, were lower length and weight, did not affect the BMI, but they had a 2.8 higher odds of being in the lower third tercile. So if you divided them into kind of the highest third, the best third of tidal volume, the middle third, and the last, they had a 3 times higher odd of being in that group with the lower tidal volume. So already you were seeing that there was some function that was being, some pulmonary function that was being impaired. So pulmonary tuberculosis was associated with subsequent impairment of lung function, basically at age 5 in all age groups. This was a table that didn't just look at wheezing, the odds of the child having any wheezing or recurrent wheezing, and that being associated with like reactive airway disease or as a precursor to possibly what we would call asthma, and it's right about kind of 2 times higher likelihood that they were going to have some problems with their lungs. But the conclusion, and I want to go because I know we're running a little over, basically children who develop pulmonary TB were more likely to subsequently wheeze. They were having some airway obstruction of some sorts. They were more likely to have poor lung function, and they were more likely to present with reduced height and weight. And so, even in our littlest patients with the minimal amount of disease, we're finding that they're starting off behind the other kids in their cohort group. They're starting off behind. So this is, something that we need to be concerned about. So I hope, over the set of populations that we presented, we're looking at the groups that don't necessarily always get voice, and we wanted to bring some voice to those today. So I'm going to stop sharing, Delphina, so we can go to questions.
All right, Dr. Armitage and Dr. Seaworth and Dr. Guy, I've got a few questions for you that have been presented in the chat. I'm going to try to give them in the order that they were received. Your first question comes from Mary Minix. She asks, have you and or Dr. Seaworth been using the 4-month regimen in your practice?
I had an N of 1. One child, and he actually got 5 months before the study information came out. So he ended up with an extra 5 months. And then, of course, I had to go back and reread all of the inclusion and exclusion criterion. But he had a very minimal, his chest x-ray was normal. And of course, I had to interrogate it twice before I actually called it that. But he was in contact with his grandma and came in with everybody else. Everybody else was sniffling with allergies. He had a cough. So very astute nurse in our clinic, Jackie Maldonado, was like, no, that doesn't seem right. She got a sputum and he grew MTB. So for him, I had, at 2 months, he still had a normal chest x-ray. So yeah, we are starting to roll that in now. But I just would say to you, be very careful. Just because you don't check doesn't mean that they don't have a positive respiratory specimen. So if you have a child with an excessive amount of disease, you don't want them to go through this treatment twice. We're seeing that every time you're getting you have treatment for TB, that is another time for it to take an attack on your lungs.
All right. So next question comes from a previous presenter. It's Rosemarie. She asked, do PTLD patients suffer from symptoms like shortness of breathing due to decreased pulmonary function? And then she follows up by asking, how is PTLD treated?
Can you hear me?
Mm-hmm.
Okay. Yes, we can.
All right. So that's exactly the point of the presentation and the thing that I found. We don't have specific treatments for PTLD because we just have not done the formal studies. Now, what we have done is actually use what we commonly use for patients who have other infections or patients who may have bronchiectasis or airflow obstruction. We would use bronchodilators. We would treat them with what we call airway clearance treatments, especially if they have bronchiectasis and a lot of sputum. We want them to have inhalers, saline, so that they will expectorate their mucus so that they keep their lungs relatively clean. But what I think the thrust of the future should be, how do we minimize the lung damage that occurs at the time the patient is not yet diagnosed, so therefore we need to diagnose early. And at the time we are treating, is there anything we can do, perhaps metformin and other agents that I'm sure Dr. DiNardo is more familiar with, as host-directed treatments to minimize the lung damage, and that has to be the focus of future research.
Yeah, I mean, to back up Dr. Guy's point, we've been ignoring the fact that it actually has an impact on the patient. So we're not even to a point where we know what to do about it yet, when we haven't even, now we know it's a problem. So there's no studies, I appreciate, Dr. Guy's input, because as a pulmonologist, she's dealing with patients who have, lung disease and have some of these tricks. But for the rest of us who are infectious disease docs who don't routinely manage patients with pulmonary disease, we're asking, should we be more liberal with steroids? Should we be using bronchodilators? Should we, is there something that we should be doing that would make this better?
Thank you, ladies. All right, next question comes from Dr. Siemens from our Q&A pod. She puts, for patients whose TB disease is treated primarily in a quote-unquote nurse-run public health clinic setting with limited access to medical care, can you recommend a questionnaire to be used by a public health nurse team to help assess, quote, post-TB lung health, unquote, as part of continuing post-treatment assessment and care?
That's a good question. So there is none that is validated for this population of patients. And as we just alluded to, there are 55 million of them that are survivors of TB that is currently estimated. So there is what's called the St. George Respiratory Questionnaire, which can come in a short form of 12 questions and a more extensive one of 36 questions. There are a whole host of questionnaires for patients who have COPD as well as asthma, but these are really directed to those specific conditions. So if I may suggest, it is probably the St. George Respiratory Questionnaire that will be more appropriate, but I have not done a systematic study of which questionnaire is most appropriate.
Even when you're in your clinic, asking the patients if they have any limitations on what they could do.
Yes.
Is there anything that you get more winded when you, that you do now that you didn't notice before you got TB? Even just starting to pull that kind of information, I think ultimately is going to be helpful.
Yes, and I thought it was a more formal questionnaire, but yes, that is a very nice beginning question. Are you short of breath doing your activities of life? And that will hit several of those measures.
Until Dr. Guy has an opportunity to work out a questionnaire for our patients.
All right, I just have a couple more questions left, and the next one is a quick one from Adesua. I apologize if I got your name wrong, but they are asking, can a baby be born with TB?
Absolutely. Congenital TB is one of the most scary things. I've had some really kind of there's one baby into my head. He was diagnosed very late, and I was a pediatric ID doc, just walked in the room, looked at that baby and said, that looks like TB. And we got the baby started on treatment, but it had already robbed that child of just most of the brain matter in his body. So that was bad. Dr. Seaworth and I always tend to get, because I do pediatrics and she does the ladies, we always tend to get those kind of right. What was it? The Monday before Thanksgiving one year, a young woman presented with a chest x-ray that had a full out miliary pattern, weight loss, fever, and we were telling them how to treat her, but we knew that baby was infected. Every part of her was just kind of like shotgun blast with the miliary, and we told them then, you need to be ready because she's probably going to deliver early. And of course, I think she delivered the day after Thanksgiving. So yes, you can have congenital TB. I don't think the numbers are as low as the literature suggests. I think it's just happening in places that's being diagnosed late and people aren't writing them up like they used to.
All right, and then like I said, oh, I'm sorry, Dr. Guy, were you saying something?
No.
Oh, okay. I didn't want to cut anyone off. All right. So then my very last question Comes
One
from
thing I
Yolanda
do-
Cantu, and
Oh.
she asks, in view of this new knowledge, what would be a gold standard of practice? What would that look like? A burning question for us all, I'm sure.
Ooh. Yeah, but I think our standard of care is going to be a little different for each one of them. I did want to circle back to the question of metformin. I don't think in the literature we're ready to start adding it to people who don't have diabetes. GI upset was a big thing in the study that I presented, where they just did all comers who had smear positive disease. But it's clearly showing that in diabetics, that medication is doing something magical. So if you have a patient who is diabetic, they are taking that, I'd sit them down and tell them, I'm like, look, in everything that I give you, that metformin is going to make it work just that much better. So if you've ever wanted a reason to get serious about your diabetes medicines, this is the reason to do it. This bug is trying to kill you, and that medication will help you. So, in all diabetics who are all patients who are diabetic, I would strongly recommend metformin. If they have a doctor who doesn't want to use it, send them some literature. Send us a request now. Send you some of the literature I have to share with them. But I think that is a something that is cheap. It's on the Walmart $4 list and has some really big implications. I guess I'd ask Yolanda, in reference to any of the things we've presented, because obviously the little people and my little patients versus the ones that Dr. Guy showed, we're going to be doing something a little standard different. But was there a particular, thing that you wanted to ask about?
It's unclear at the time, but what I can recommend for Yolanda is to follow up with either of our many TB experts here at Heartland and any of your available resources, and I'm sure that we could all give you a much clearer answer based off of the situation that you're presenting us with. So with that being said, that covers all of the questions for this section of our TB webcast. I want to thank all of our presenters. That includes Dr. Seaworth, Dr. Armitage, and Dr. Guy. Thank you so much. And then I'm going to go ahead and transition us into our next break. So Delphina has some important information to share, but before I give you all over to her, I'm back again with another TB swag bag question. Now, Annette, because you've already won, that doesn't mean you get a second one. You got to save some for the rest of them. So here comes the second question. Now, remember, I need you to put your answers inside the meeting chat. So my next question for the TB swag bag is as follows. In 2021, Texas is one of the 6 states with reported incidences of TB above the national average of 2.4 persons per 100,000. Which of the following answer choices is the correct overall TB incidence rate for the state of Texas as reported by the CDC? Is it A, 3.2, B, 3.4, C, 4.2, or D, 4.5? Give everyone a chance to answer real fast. And oh boy, I see a lot of people that know our state rather well. The correct answer is actually B. It's 3.4. So that means Mary Menix, you are our winner for our second TB swag bag question. Just like I asked Annette, in just a moment, I'm going to drop my email down below, and then you can send me the shipping information that you would like us to send your TB swag bag to. Now, just to make sure that we're all understanding, I do have some charts to share because charts are fun. So the first answer choice of 3.2, that goes to Maryland right here. And then, of course, we have Texas with 3.4. Houston actually turns out to be the number with 4.2. And then California happens to be that 4.5, that answer choice D number right there.
Hi, my name is Andrew DiNardo from Baylor College of Medicine and Radboud University. I split my time between patient care and running an immunology clinic in Eswatini. A few years ago, we identified that even after successful treatment, TB patients retain detrimental epigenetic scars, DNA hypermethylation in genes critical to immune function, and that these epigenetic scars persist at least 12 months after successful therapy. So for the past 4 years, we've been wondering what the clinical results are of the immune system not going back to normal homeostasis even after successful eradication of the microbes. Here is a study published in 2008 that shows the probability of being alive 16 years after successful TB treatment. You can see that compared to age, sex, race, and HIV-matched individuals, the TB patients continue to die at a rate much higher than their propensity-matched controls. So we did our job, we killed all the microbes, but now we are asking how we can help restore immune homeostasis and help our patients have a normal and healthy life after TB. Every year, there are 10 million TB cases worldwide. Of those 10 million cases, 1.5 million will die each year, or 7.5 million over a 5-year period. 2% will have relapse, meaning there will be approximately 200,000 relapse cases each year. But in addition to the in-treatment mortality and the relapse, the risk of post-treatment mortality is 2.1 to 6.1 per 100 patient years, which means approximately 300,000 post-TB deaths will occur in the 5 years after successful TB treatment. Of those who have post-TB mortality, the two most common causes are cardiovascular disease and cancer, both of which occur around twofold at increased risk compared to propensity-matched controls. Finally, those that do survive, 15% will have severe lung dysfunction, as defined by an FEV1 of less than 50%. So how can we decrease post-TB morbidity and mortality? Currently, we don't have answers. Lots of ideas, but no answers yet. These two studies, the top left, done by Bob Wallace and his colleagues in Johannesburg, looked at everolimus and a couple other host-directed therapies, not to improve killing of TB, but to improve lung function at the end of TB therapy. The second study, done in non-diabetics who had TB, were given metformin and were found to have improved lung health at the end of TB therapy compared to those who got the placebo. Here's our data from our Eswatini cohort. What you can see here on the y-axis is CRP, a common measurement of inflammation. The dotted line at 3 represents a line that increases the risk for cardiovascular disease. If you have a CRP greater than 3, you are at increased risk of cardiovascular disease and cancer. As you can see, the majority of TB patients have elevated CRP, and that inflammation decreases with therapy. But you can see that 52% of successfully treated TB patients are still hyperinflammatory at the end of therapy. On the right, here you can see potential biomarkers to help us identify post-TB morbidity and mortality. At the end of TB therapy, a good number of TB patients still have persistently elevated CRP, IL-6, and TNF. CRP, as you can see, overlaps as a biomarker that helps predict cardiovascular disease and lung dysfunction. In the coming years, we need to evaluate which of these biomarkers can help us identify post-TB morbidity and mortality. Finally, this is the EZ1 spirometer. As you can see, it is small, about 1.5 times the size of a typical smartphone. We've already started using this in Eswatini and are slowly rolling it out at our Bentab clinic. It takes 5 to 10 minutes to use, and since the pandemic, they fitted it with a filter so it can be used before patients are culture negative. Therefore, we can track lung function with successful therapy. Instead of just trying to kill the microbes, we can focus on how to heal the lungs at the same time. Finally, I wanted to share a little bit about the Bentab TB clinic that is co-run by Dr. Guy and myself. As mentioned, we're starting to roll out lung function on nearly all of our TB patients. If TB patients have extrapulmonary disease, other unexplained oddities, we are happy to initiate immune dysfunction workups. For anyone with extrapulmonary disease, drug resistance, HIV, GI disease, or other reasons for suspected malabsorption, we also implement therapeutic drug monitoring. Please contact us. We're happy to help see patients once or twice, or as many times as you would like. If you have any questions about the presentation, please reach out to myself, Dr. Guy, or Josie Aravello, our nurse practitioner. Thank you.
Hi, I'm Lori Eidelbach, TB Program Manager for Williamson County and Cities Health District. And for World TB Day, I want to tell you about a wonderful grant we were awarded by the CDC. It's the CDC's LTBI grant for status adjusters. I need to give a shout out to our Clinical Services Director, Caitlin Murphy, who was unable to join me for this presentation, but was the one who spearheaded the application for this grant. Before I go into details about the grant, let me give you a little background and statistics. Approximately 71% of TB disease cases occur in non-US born persons. Only about 13% of TB disease cases come from recent transmission. That means the majority of TB cases occur when long-standing LTBI progresses to TB disease. Since status adjusters are non-US born, they are at a higher risk for LTBI and development of TB disease. Improving awareness of and linkage to LTBI treatment among the status adjuster population is an important disease prevention opportunity. Let me define for you some of the words you just heard me say. Status adjusters are non-US born persons living legally in the United States on temporary visas who apply for permanent residency. Some temporary visas include student, employment, tourist, family, etc. And the adjustment of status is the process used to apply for lawful permanent resident status, also known as applying for a green card. Civil surgeons are physicians designated by the USCIS to provide medical examinations for status adjusters. So the full name of the grant is Strengthening Civil Surgeons' Capacity to Improve Latent TB Infection Surveillance and Outcomes Among Status Adjusters. In October 2022, the Department of TB Elimination launched a new 2-year cooperative agreement with 4 recipients to support the creation of pilot projects to prevent TB disease among status adjusters examined by civil surgeons. The goals are to establish surveillance and improve linkage to care and treatment of LTBI for status adjusters through the collaboration between health departments and their civil surgeons. Grant recipients include California Department of Public Health, Florida Department of Health, Minnesota Department of Health, and us, Williamson County and Cities Health District. Part of the arduous application process required we partner with at least one, if not a few or many, high-volume civil surgeons, those civil surgeons who diagnose at least 10 LTBI clients a month. We were fortunate enough to identify 2 high-volume civil surgeons who feel as passionate as we do about the grant's mission and who were willing to put the hard work in with us to meet our goals. Recipients will engage civil surgeons who commonly report LTBI cases, implement interventions to improve treatment initiation and/or completion among status adjusters with LTBI, generate pre- and post-intervention LTBI care cascades, including number of status adjusters tested, having a positive IGRA result, receiving a chest X-ray and a diagnosis of LTBI, initiating LTBI, and completing LTBI treatment. And then we will submit data to the CDC throughout the project. Our directive is to figure out why status adjusters fall through the cracks, why maybe they are not getting referred, why some become pre-treatment lost to follow-up, why some may not finish treatment, and why we might occasionally have post-treatment disease recurrences. Certain gap interventions will include ways to reduce loss to follow-up during treatment and to address status adjuster and civil surgeon needs, including psychosocial needs, transportation issues, nutritional deficits, etc. So with all that said, we're honored to have been selected for this grant and are excited to see how we can make even more of a difference in our community and work toward the end goal of TB elimination in the US and worldwide. We look forward to sharing our findings and results with you as we progress through the grant process. Thank you.
Good morning. My name is Joe Paul Gallo. I'm the Divisional Manager for Disease Control Prevention for Denton County Public Health. First, I'd like to thank Heartland for the many years of service, and for me personally, for the last 11 years, it's been a wonderful relationship. I'm going to ask today to present the similarities of patients with diabetes, patients with tuberculosis, and case management. Why should we be concerned? Diabetes is a tuberculosis risk factor. Persons with TB infection and diabetes are more likely to develop TB disease than those who do not have diabetes. Diabetes causes a 3-time increase in tuberculosis risk and a 2-time increase in adverse TB treatment outcomes. According to the CDC, 1 in 4 people with TB disease also have diabetes. What is the relationship? Both are manageable diseases. Medication compliance is the key to successful outcomes, and effective case management leads to medication compliance. I was asked to speak because from 2012 to 2022, Denton County Public Health annually successfully managed more than 600 high-risk diabetics. Of those 600 annually, we reduce the A1C in 80% of those patients every year. By reducing the A1C, it's estimated that savings was over $800,000 in complication cost. This can relate to your tuberculosis patient also. How are they similar? It's case management, TB case management, diabetes case management, medications. TB is curable with medications. Diabetes is controllable with medications. We do group and individual education in TB. We educate the family. In some cases, we are required to go out to the employer and explain the risk of TB and the differences between infection and disease before the employees are allowed to come back to work. In diabetes, we work with groups as faith-based, church, school, individual education with the patient and their family. Same with TB. Got to educate the family for the support system. We do home and office visits. You have to lay hands on the patient. So the patient comes in for their TB visit every 30 days. In diabetes, they come in every 30 days to 90 days. We do laboratory services. We have to do the baseline for TB patients, and we do baselines for our diabetic patients. But through the treatment and case management, we run laboratory services throughout their treatment. Screenings. We do screenings, contact investigation, looking for those that have been involved with individuals that have tuberculosis. In TB, we screen for the disease out in the public, maybe at schools, churches, even the family members. And then we do DOT and VOT, the asynchronized video platform that we use for our diabetic patients and TB patients. Both have been great success. We found that with our TB case management and VDOT, we applied it to our diabetic case management group, and it was just as successful. So here are some of the reasons for success. I think you'll all agree. Constant contact via phone, text, home visit, electronic synchronized platform, medication tracking. Our electronic asynchronized platform does the medication tracking for us. Require office visits. We have to lay hands on the patients. We have to look at them. We have to talk to them. Create a caring environment. As you know, in our diabetic patients and our TB patients, we have anger, we have denial, we have resentment. Sometimes in the beginning, it's very, very difficult for the case manager, but over a period of time, everything seems to work out. It seems to have a long-term, fostering a long-term relationship. We involve our CHWs and our social workers to assist in social services. The patients in isolation, and they can't get out, so they need food. We go to the food bank, and we have our CHWs work with them or family members to try to get them what they need. Same with our diabetic patients. If they're not eating correctly or they're not having a correct diet, we get the CHW and the social worker to maybe help them and guide them in food selections. But I think we'll all agree, case management is a constant contact and creating a caring environment. I'd like to thank all, and if you have any questions, feel free to email me. I'm sure the slides will go out. And again, I'd like to thank Heartland for all the work that you do. Thank you.
Hi, good morning, everybody. My name is Barbara Martinez. I'm the Clinical Health Services Division with Fort Bend County Health and Human Services. It is a pleasure to be here today as we celebrate World TB Day. Today, I am going to be sharing some information about a project that we had back in 2020 to increase the awareness of latent TB infection to our providers and our community members, and especially those of Asian and Asian Pacific descent. So increased latent TB referrals using mini grant funding. And for today, so, our agenda for this project, as I said, was increasing awareness, increasing our latent TB infection referrals, targeted testing, identifying ongoing barriers, and of course, at the end, we were able to answer questions related to latent TB. So how did we do this? We actually found several of our physicians, our community physicians, who are of Southeast Asian and Asian Pacific descent, and we took information to them. We took educational materials to them to encourage them to promote treatment of latent TB in their own patients. We know that oftentimes a lot of our docs are a little bit hesitant to treat latent TB. So we provided them information on best practices and encouraged them to provide to their patients and send us the referrals. So this is our kind of what we saw as it related to our referrals. In 2020, we had only received 85 referrals. And of course, we have to turn in, some COVID numbers, and there are probably some effects of COVID. But as you can see, after we started our project, we actually increased our referrals up to 176. And now remember, this was still during COVID vaccine time and during times of social distancing and all that stuff. So obviously our ability to provide that education to the providers had a great impact on what we were doing. So we, you can see how in July, when we actually started the intervention, we really were able to pick up the number of referrals. So we created workflow specific, and then we had one nurse that was assigned to do nothing but LTBIs so that we could improve the turnaround time of having the patient seen and started on meds. For 2022, as you can see, our referrals continue to climb. We have 108 referrals, even though we were unable to secure the funding for the mini grant once again. But we continue to work with our providers in increasing our referrals for latent TB infection. Then we also had our very first targeted testing in Fort Bend County, and it was to celebrate the 75th year of independence of India. And our mobile health unit and our TB team went out there, and they provided education, and they actually did T-spots and were able to provide education to the community. Fort Bend County is the most diverse county in Texas, so we were excited to be able to do this, and we will continue to partner with our community to bring more targeted testing. That's one of our goals this year. So, of course, continued barriers include the lack of awareness among Asian Americans regarding the treatment of latent TB. There's really no awareness on how to recognize the transmittability of TB, and there's a fear of testing and treatment and the stigma around TB that continues to surround, just the continued of TB. Again, fear of being stigmatized in the mainstream community if they tested positive. And the people with LTBI frequently experienced or feared gossip and avoided friends and acquaintances. And in small communities, discrimination, of course, make people feel socially isolated. Even entire families can be shunned. And TB is often attributed to women. So the women who may have TB disease or even latent TB, the men may get divorced or they're considered unworthy of marriage. So we're still fighting that stigma surrounding TB. So that is a quick synopsis of what we did. I thank you guys for the time. Let me know if you guys have any questions or comments. My information is here at the end of the slide. Feel free to give me an email, shoot me off a quick email, and I'll be happy to answer. Happy World TB Day, guys. Continue to fight the good fight. We know that we are the ones that provide a voice to those that may not have one, and we're the ones that have to take the front line of getting rid of the stigma and providing the education not only to our patients, but our communities and our physicians. Thanks.
I want to talk about research that we're doing at City Chest Clinic here in San Antonio. First, I want to point out the TB Trials Consortium. The TB Trials Consortium is basically the CDC-funded body that looks at the regimens that we use in the U.S. for treatment of patients with either latent TB or active disease. And there's just been a recompetition of the TBTC this last, 2 years ago now, in 2021. And it's a 10-year cycle. So San Antonio received one of the sites for participation in the consortium. There were 4 VAs and 2 public health centers that were funded, and the San Antonio VA happened to be one of them. Most of you know about Study 31. This was the treatment shortening study for TB disease. It looked at rifampin, rifapentine, and moxifloxacin containing regimens to shorten treatment from standard 6 months down to 4 months. So this study started in January of 2016. The final data collection was July of 2020. And this was as part of the prior TBTC funding cycle. During that cycle, San Antonio VA, in partnership with City Chest Clinic, was one of 33 study sites worldwide and one of 5 U.S. study sites. So San Antonio, as a whole, between the VA and City Chest, remained one of the top enrolling sites throughout the entire course of the study. And also, interestingly, our very own Dr. Barbara Seaworth worked with the Community Research Advocacy Group, so Craig, to ensure that patients were treated humanely and given equal opportunity to participate at all study sites who were involved. So now that Study 31 is completed, we're getting geared up for Study 37. This is a treatment shortening regimen for a TB infection. So the goal is to compare the safety and effectiveness of 6 weeks of daily rifapentine. So we've gotten the regimens from 9 months of isoniazid down to 3 months now. We're looking to see if we can go down to just a month and a half with 6 weeks of daily rifapentine. This will be the comparator arms would be also 3HP, which is the weekly INH rifapentine dosing, and then compared to 3 months of INH and rifampin dose daily, or 4 months of rifampin alone dose daily. I wanted to also acknowledge the contributions of Dr. Mark Weiner. Dr. Weiner was a champion of TB research in the TBTC. He worked with TC and outcomes and research, and was, the lead for the site here in San Antonio for many years. But he retired last year. I just want to acknowledge his role in research in San Antonio, but also research in the U.S. overall.
Hello, everyone. My name is Dr. Larry Schlesinger, and I'm the President and CEO of Texas Biomedical Research Institute. I am so pleased to be with all of you today on World TB Day. Being a tuberculosis researcher myself, I can tell you that we have made great strides in our research and clinical arena with tuberculosis, but we have a long way to go. And in that context, in the few minutes I have with you, I'm going to talk about a new exciting program to train the next generation of tuberculosis researchers. And we need them if we're going to make major steps forward in tuberculosis. I'm going to talk about an inaugural center funded by the National Institutes of Allergy and Infectious Diseases. It's called the Interdisciplinary Next Gen Tuberculosis Research Advancement Center, or INTRAC. And I'm very pleased to talk to you today because this is a partnership that includes the Texas Center for Infectious Diseases and the associated TB clinics. So I'm going to go through this rather quickly, but I'm going to tell you more about this exciting new program that we've established and are implementing. But before I do, let me add a slide or two on who Texas Biomed is and how we contribute to the tuberculosis research arena. So we are a leading research institute pioneering and sharing breakthroughs that protect you, your family, and the global community from the threat of infectious diseases. We're an independent nonprofit research institute with over 400 employees, the demographics of which are located on this slide. We're on a nice 200-acre campus on the interior west side of the city with a large amount of laboratory space, including biocontainment level 3 and 4 facilities. We don't have siloed departments here, but rather interacting scientific programs, and we also house one of 7 national primate centers with a broad range of primates, rhesus of which are used in tuberculosis research, as well as our rodent models of tuberculosis. We are a very large group at Texas Biomed. I'm showing you again the faculty and staff within the tuberculosis program here and our nearly $20 million of active funding from a number of agencies, a number of papers we published. One of the unique aspects of Texas Biomed is we've invested a large sum of money in putting advanced technology in our biocontainment level 3 space so that we can work with living animals and tissue culture, etc., within the BSL-3 facilities and study a range of research technologies related to tuberculosis in our models. So what is INTRAC? INTRAC is a 5-year, nearly $6 million grant to fund the next generation of tuberculosis researchers. It's primarily to attract the next generation of diverse researchers to the TB field and to train in a multidisciplinary skills and real-time world experience, of clinical tuberculosis. What is really emphasized here is that we take researchers from the bench to the bedside throughout this program and give them the necessary tools that will enable them to be successful as they move forward in their careers. The way that Texas Biomed INTRAC is set up is among several cores that are located on this slide that you can see here: administrative development, biosafety, biocontainment, research imaging, animal model core, and clinical research and patient care. We have leaders in each of these groups, and these are comprised to create a curriculum. The curriculum, the details of which on the right side of the slide isn't necessary, but we create a personalized curriculum for each participant based on their already accomplished technical expertise regarding to tuberculosis, and then we establish a program of learning going forward. Here on the left-hand side of this slide is just a range of online on-site training courses that we have within INTRAC, and you can see them there listed. In addition, we've engaged a number of outstanding experts from around the country that can broaden the skills that we bring to our trainees within INTRAC by engaging them as a faculty to participate in classroom or experiential learning. What I'm particularly pleased at is this formalizes our ongoing relationship in clinical research and patient care, working with Blanca Restrepo, Lisa Armitage, Barbara Seaworth, and myself within the inpatient environment at Texas Center for Infectious Diseases, as well as the associated TB clinics, where trainees within INTRAC will have firsthand experience in interacting with professionals in the TB arena and working with patients to understand how to improve their clinical outcome. We also have at the border, through Blanca Restrepo's partnership, a clinical research site where across the border we can be studying tuberculosis in a unique cohort of patients that include those with diabetes and obesity and tuberculosis. And this is a particularly important part of our research program that's recognized by the NIH. And finally, I'd like to say that this is also a program of continuous learning. As you can see on this slide, we have classroom learning. We have the opportunity to provide pilot research grants to our trainees. We can have workshops in manuscript writing and mentoring. And we have monthly INTRAC meetings where we come together and talk about a variety of issues. And with that, I'm excited about this new initiative just launched this year and engaging our partners as we enlarge our research and development pipeline for tuberculosis from the bench to the bedside. Thank you.
Hello, everyone. I would like to take the next few minutes to tell you about Heartland National TB Center and our upcoming trainings and product updates. Heartland National TB Center is recognized and contractually funded by the state of Texas to provide excellence, expertise, and innovation in training, medical consultation, and product development to reduce the impact of tuberculosis throughout the state of Texas. We are excited to announce the following upcoming trainings. Introduction to TB Nurse Case Management Online, scheduled to start April 25th. This introductory course covers the basic elements, knowledge, and skills essential for the nurse case manager responsible for the care of patients with active TB disease and their contacts. Essentials of TB Nurse Case Management Online, scheduled to start May 18th. This course is intended for nurses and public health staff who are actively engaged in the identification, case management, and treatment of patients with tuberculosis infection or disease. TST, Train the Trainer with Practicum, an in-person training scheduled to start June 6 in San Antonio, Texas. This course is designed for TB personnel responsible for training staff and other healthcare workers on the proper placement and reading of the tuberculin skin test. TB Updates, an in-person training in Houston, Texas, scheduled for July or August. And this is an advanced course, and it is intended for physicians, nurse practitioners, and registered nurses with direct experience in the management of patients with or at risk of TB. Registration is now open. Please visit our website for more information. Now I'd like to tell you a little bit about product updates. We have case studies in tuberculosis, training, and nurse case management. This is a collection of nurse case studies and accompanying tools. The studies in this book are based on real-life experience of TB nurses in the Heartland region and beyond. They are designed to illustrate key concepts in TB prevention and care and can be used to train new nurses and other healthcare providers who are inexperienced in TB case management. Next, we have tuberculosis medication side effects questionnaire. This questionnaire contains visual analog scales for each of the specific adverse drug reactions. It is now available in English and Spanish. Rash Assessment and Description Guide. This two-sided product will guide healthcare personnel in the assessment of adverse drug reactions. This product is available now for download on our website. For more information on our trainings, please visit our training page using the following QR code, or you can go to www.heartlandntbc.org.
Hello, everyone. My name is Taiwo Ajayi. I am a Bachelor of Science in Nursing prepared registered nurse, and I am also currently a Doctor of Nursing practice student with the University of Texas Health San Antonio. On this World TB Day, I would like to present to you an initiative titled Tuberculosis Medication Side Effects Questionnaire, which is currently being implemented in the Quality Improvement Project to help facilitate patient communication of reportable adverse reactions from tuberculosis drug therapy. In collaboration with the Heartland National TB Center, this project is being done at the City Chest Clinic in San Antonio, Texas. I would begin by giving a brief overview of the project. This project stems from the knowledge that tuberculosis is a disease which can lead to mortality and requires prompt and close monitoring of adverse drug reactions during drug therapy. In fact, literature reveals that out of 552 active TB patients, 82.5% of patients undergoing TB drug therapy communicate at least one adverse drug reaction in the first 2 months of therapy, and 78.8% of patients communicate at least one adverse drug reaction during the entire TB drug therapy period. This project is being implemented at the City Chest Clinic, which is a TB clinic, and to show that there was an opportunity for improvement, on-site chart audits revealed that within a 3-month period, only 40% of active TB patients seen during monthly clinic visits communicated at least one of 10 priority adverse drug reactions in the TB 205 form, which is the toxicity screen checklist. The TB 205 form is a checklist of 36 side effects with which patients are required to answer yes or no to indicate that they are having a side effect or adverse reaction. However, the medical directors of Heartland National TB Center highlighted 10 priority adverse reactions, which aligns with the CDC recommendations for priority adverse drug reactions when it comes to TB drug therapy. So the project goal is to utilize an evidence-based intervention to increase the percentage of active TB patients who communicate at least one of the 10 priority adverse reactions from TB drug therapy from 40% to 60% at the City Chest Clinic during monthly visits over a period of 6 months. So the implementation of this intervention began on October 1st, 2022, and is scheduled to end on March 31st, 2023. The evidence-based intervention found based on literature were called visual analog scales. This slide shows a list of the 10 priority adverse drug reactions. And to the right is the tuberculosis side effects questionnaire, which is the intervention that was created for this project. The tuberculosis side effects questionnaire contains visual analog scales for each of the specific adverse drug reactions. The visual analog scale is usually a 10-centimeter line anchored on both ends by descriptors of a specific adverse reaction or side effect. One end of the line represents a description indicating an absence of a side effect, and the other end represents a description of the patient experiencing severe side effect. Patients are usually asked to put a mark on the line to indicate how severe they are experiencing a side effect or adverse reaction. Literature reveals that to ensure higher sensitivity in the use of visual analog scales, the line usually should be plain and not marked or divided at intervals by numbers or indicators. Each image for each of the adverse drug reactions helps to enhance patients' visual symptom perception, leading to improved patient self-reporting of adverse reactions. So far, with the implementation of this intervention, there has been a significant increase in the communication of adverse drug reactions at the City Chest Clinic. And this tuberculosis side effects questionnaire is also available in Spanish. We call it side effects and not adverse drug reactions so that patients do not get afraid of taking TB medications. Here are my references. This is my email if you would like to contact more information about my project. Thank you.
And if there's a break, that means I'm back. So I've got another TV swag bag question, y'all. Get ready. It's the last one. Now, Mary, you also are no longer eligible to receive another bag. You gotta share. So here comes the third and final TV swag bag question for this webcast. Now remember, you want to respond to the chat, not the Q&A pod. Here it comes. Our third and final question is, according to the CDC, Texas is one of 4 states to make up the majority of TB cases throughout the United States in 2021. The other states were California, Florida, and New York. No surprise there. Where did Texas rank amongst these other states when considering their percentages of all TB in the states? Did we come in first, second, third, or fourth place? And again, I see so many people that are very familiar with our state. And I'm seeing that the correct answer is we came in second. Like, usually we're number 1, but I think we're okay with conceding that we're second, given the subject matter here. So in that case, my very first correct response that I received came from Tommy Camden. And Tommy, you're just down the hallway from me, so I'll just deliver it to you, sir. So in the meantime, thank you all so much for participating in our TV swag bag giveaways. We love having them. We usually have them throughout any and all of our trainings. So if you're ever considering whether or not to have Heartland host a training for you at one point, just know that we come with our own swag and we will be happy to give it away. So because of the fact that we're running just a little over time, and that's perfectly fine, but we do want to respect time, I'm going to go ahead and yield the floor to our next speaker, Elizabeth Reyes, although I call her Liz, and she is going to be telling us about the We Are TB and Almost TB program. So I'm going to let her take it away from here. Welcome, Liz.
Sorry for the technical difficulties I'm having over here. Hi, my name is Elizabeth Reyes. Like Lauren said, they call me Liz, whatever is easier. I am here to talk about We Are TB / Somos TB. Um, it's a wonderful organization that I'm glad to say that I am a part of, that I was able to join. One thing I would say is I wish I would have heard about this organization while I was going through my TB treatment. It would have made a big difference. Um, a brief description here: when you first enter to the We Are TB, it gives you a brief summary of the organization stands for, which is basically a TB survivor and advocate group where there is, of course, no judgment, no stigma. They don't stigmatize you. Um, I can personally say when I first found out that I had TB, the first person to stigmatize me was my dad. Of people, he was the one that put the big fear on saying that I had TB, which was kind of scary to get out of that stigmatized. I'm saying I wish I would have known about this beforehand. I wouldn't have been so scared of at the beginning of knowing that I had TB and what it actually meant. Um, we do meet every Monday at 8 p.m. Eastern time, 5 p.m. Pacific time, and it's via Zoom. And there is every Monday in the morning, they send a link just to reconfirm everything is said. And for Somos TB, we get together the second Tuesday of the month because it's not as many members as in TB. So that is something that we're actually working on and trying to get more Spanish speaking, whether they're former or current patients of TB, to join the group. And we do offer, it's an amazing support system of people who have actually gone through the treatment, have, experiencing all the side effects and everything that comes with taking the treatment for TB, having to go through the 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 trauma basically that happens to us while we're patients or are currently going through that treatment, that they're able to tell us on how they feel emotionally, how it's taking a toll on them, or how it's helping them, how the doctors, nurses are helping. And of course, it doesn't offer any medical or legal advice, but it's just a great part where you can just talk. You have amazing people that are, listening to you and, giving you the support that you want and need at the moment. And they do advocate, which is amazing. I know right now a good portion of the We Are TB people are in Washington right now. They're advocating, of course, with our lawmakers and our politicians to, get more financial support to eliminate TB and bring more awareness to this disease that, unfortunately, we still have around these times. And they do a great job with educating on what is TB and how you can get the help and the treatment that you are getting and you are needing, but sometimes you also need that, I'm sorry, you need that, support that sometimes a lot of people don't get because they don't understand what you're going through and what you're experiencing, because there's not a lot of people that have gone through TB. Like I can say for myself, when they told me I had TB, I was like, oh, this is probably going to be a couple of weeks of treatment. I was remembering when my dad had gotten E. coli that he did, I think, 2 weeks of treatment. I was like, okay, 2 weeks, I'll be done. I'll be out the hospital. Didn't know anything about TB. Didn't know I was going to have to do a 17-month treatment. So that's one thing that I'm really loving about it, that especially for patients or for some of the members that are currently being patients, to know that, it's going to be a journey, but it can also be an amazing journey where they can learn more about what tuberculosis is and how, how your life is affected afterwards, not just currently, but afterwards. And you have the people that are there that of course know what you're going through and what you can expect afterwards. And I can honestly say, since I was a patient at TCID, I was able to talk to other patients here, and we made our little community, our little family that we can talk to, but we really didn't know a lot about TB. So a lot of our complaints, we thought it was just, our bodies. We didn't know it was secondary effects to some of the medicine that now, sometimes when they say like, oh, was that because of the so and so medicine? And we say yes. Like, I remember the first time I joined, they asked me, they're like, do you still get night sweats? And I was like, no, that stopped. And then I thought about it afterwards, and I was like, I do still get, but I don't get them as severe as I used to when I was going through before I started my treatments. And that is something that I actually never considered thinking about, that I was gonna have, the effects lingering still afterwards, which was very nice. And even now that I'm there and I'm constantly talking to them, when I got to meet them in person, I was like, this is amazing, because I know you through Zoom, and now I'm getting to meet you in person, and you feel that they're like a second, third family to you, because they know exactly what you've been through and what you've gone through. And like I said, I wish that was something that I would have loved to have had being while I was doing my treatment, because it would have made a big difference, as into when my dad first stigmatized me with TB. I know it took me months to officially tell my friends and the rest of my family that I was suffering with tuberculosis. I would just be like, no, it's just a disease, it's just a disease. And I wouldn't explain it because I really didn't know what TB was. I would say till I got here to TCID, which was 3-4 months later, and I was able to officially tell my friends and family about when I was 7-8 months into treatment that I had TB, because I didn't know, I wasn't educated, nobody told me exactly what it was. So having that support system and knowing that we're able to help other people that are going through it right now, I feel like it makes a big difference to them. And they've said it to where now they're not only getting the doctors and the nurses perspective on what to expect, they're getting now the actual people who have gone through it. They're getting their personal testimony basically on what it is. And that's why I'm so happy and I'm so glad I got to join this wonderful organization. The only thing I have is I wish I would have known about it before, not after my treatment was done. So that would have been amazing. And they do have their Facebook page, We Are TB. They have it also on Instagram and on Twitter. They are more active on Twitter than what it is on Facebook and Instagram. And that's all I have to say, guys. I don't know if you have any questions for me personally.
Yeah, thank you so much. Thank you so much, Liz, for that wonderful presentation and for sharing your experience with us. If anybody has any questions for Liz, you can go ahead and put them in the chat box. Unfortunately, I know we're way over time, but again, thank you so much, Liz. Before we go, I need to put up a few slides, and I want to apologize sincerely for all of the problems that you're having with Cloud CME. This is the first time we're using that program to acquire CMEs. Again, we're only able to provide CMEs for physicians for this webcast. We were not able to secure CNEs for nurses or CEUs for other healthcare personnel. But I can send everyone a certificate of attendance, and I'll do that after the webinar. But before we go, I need to share. Give me just one moment because I need to share the evaluation slide. So, okay, so hopefully everybody can see this on the screen. Just quickly, I just want to announce that you will probably be receiving an email from us or a notice of the 2023 Heartland National TB Center Needs Assessment. And this is very important because this is what we use to provide you with the trainings and products that you need that are of most interest to you and your organization. So when you see this come your way, please be sure to fill it out. We hope to get this out probably within the next month. We still need to go through the approval process and review process before we finalize the needs assessment, but you can expect it to be coming your way within the next month. I just wanted to give you a heads up on that. Next, I just want to ask everybody to please complete the Heartland evaluation for this webcast. We rely on your feedback to improve our trainings, our webcasts. So please be sure to complete this evaluation. You can use the QR code, you can scan that, or you can copy and paste the address below into your web browser. And then we'd like to ask everybody to please complete this evaluation no later than next Wednesday. And if you have any questions, please, for me or for the speakers or anybody on the webcast today, feel free to leave them in the chat box. Again, I'll get to answering all of the questions in the chat box regarding the CME, the Cloud CME app. I apologize again for all of the trouble you've been having. Again, we will be able to send out certificates of attendance to all participants. Thank you everyone for being online, for staying online with us. I know we went way over.
Thank you.
Just want to jump in and say thank you for everyone for joining us. We're excited here at Heartland for our partnership with the state, and we're looking for the opportunity to do a lot more exciting things. I know we ran over, but you guys were great. Thank you so much for your questions, for being so engaged, for standing with us. And I can't just, again, Barbara Martinez was saying earlier today, advocacy for our patients, it starts with each one of you, and we're just so appreciative of the opportunity to work with such a great group of folks. We appreciate y'all. Just see what wanted to say anything.
Nope, Lisa said it all. Thank you. Take some time for lunch.
Yes. Celebrate yourselves today. You guys are awesome. Thank you.
All right, thanks everyone. Bye.
Bye. Thank you.
Thank you.